Welcome, sons. Hello. Are you guys here? We're really excited to get started today. We're going to start on time only because we have action packed. I'm Sherry Cisneros, Substance Use Navigator Director for the California Bridge. We're very excited to have you. As usual, we have so much information to go through. We're going to kind of mix it up today, but before we get started, for your best experience today, connect your computer to a power outlet. We don't want you to have a power shortage when you're in the middle of something good. Close any unnecessary windows. That really helps. Use the chat for your questions, and please make sure it is addressed to all panelists and attendees. And then closed captions will be available throughout the session, okay? So let's get started. I'm glad to see we have Rebecca from Folsom, Eric from Arrowhead. Welcome, that's Southern California, that's where I am. Alicia Brown from Modesto, Troy, again, Southern California, Orange County. Well, welcome everyone. I'm so happy. I want to give you some updates real quick before we get started. But just to let you know where you're at, you are at the Sun Training 101, Connecting Patients to Ongoing Care, brought to you by California Bridge. We have today's agenda, and we're going to mix it up because we have a special guest, Josh Leftig. If those who know him, he's been a founding member of the California Bridge, and he's going to talk about the naloxone distribution program. But he is on another call, so he's going to come at the end. So everything's going to kind of be moved up from that. So this is today's agenda. These are our objectives. So we have a few, so we really need to move forward and make sure that we're meeting all of these. And they're just listed, and it's basically getting you strategies and resources for ongoing care. So we're going to come back. So we're before we get started, I have a few things if you guys want to type in chat before we get started. We are growing. Currently, we have over 100 sons at approximately 99 sites. So we are halfway into our California Bridge BHPP grant. We still have 100 sites, more or less, to continue. So that's where we're at. So we're only growing, and growing, we have some growing pains. So I'm going to leave you with some homework at the end of this session. The first thing is to know, does your hospital operator know of your program? Is that some education teaching that you've been focused on? We've had some feedback from recent hospitals explaining that, they called a hospital operator and they didn't know where to refer. So we're going to work on this a little bit more. More information is to come, but I just kind of wanted to reach out to you guys and see if your hospital operator would know about your program and you, if they could refer you. But before we get started, we want to also know, as the second thing I wanted to go over, is what phone number would you like to have on our California Bridge hospital site? Is it the hospital overall general number, or would it be the ED? If a patient was in crisis or wanted buprenorphine treatment, which phone number would you rather have our site endorse and promote? So please let us know. You can type it in the chat, but we're, again, more to come. These are your homework questions. You don't have to answer now. What we are going to answer is a poll. We're going to do a poll. We're going to start today on a note about a poll. Are you currently giving buprenorphine in your emergency department? We want to know yes or no. Why is this important? Because some sites are just referring to clinics, and that's quite all right. That is totally acceptable. But we just kind of want to know, so that way we can tailor make our next series of sessions more tailor-made to what we can help you with. Again, we do evaluations, but we're always trying to adjust our trainings to make sure it's actually fitting with what you guys are experiencing out on the field. So again, please answer the poll. We want to make this interactive. So please, please answer the poll. And we're going to be doing many of these throughout the day. This is more casual and interactive. So please type your responses in the chat. We have our Sun mentors are here to answer questions. And so that is our poll. Caroline, do you have the answers? We're going to close it up. So we have 82%, 37 sites say yes. So congratulations, that's half the battle, right? Getting that buprenorphine on the formulary. And no, 8 sites do not have it, and that's okay. That, like I said, if you have a robust referral system, because sometimes our patients are not 12-hour opioid free or whatever the criteria is for those, the opioid free. So it's okay. We'll work with that. Definitely. Thank you. So starting, again, we have another poll that we're going to ask. And this poll is, where are you sending your patients? Okay. Where are you currently sending your referrals? Is it mostly inpatient, outpatient, primary care providers, federally qualified health centers, or telehealth? Okay, I know during COVID, that's where all of the referrals were going. If you're in a rural setting or, you know, a place that nobody was coming into the ED, very, very slow. So that's why we're asking. We just want to know currently, right now, because we know on Slack, there's been an increase of patients. So we kind of want to fill you guys out. So, you know, where are we sending them? And these are the different places on a screen. We can send them to inpatient detox rehab, sober livings, outpatient, residential, hospital clinics, if you're fortunate to have a clinic within your hospital, federally qualified health centers. Those are popping up and they're everywhere. They're really good for primary care as well. And of course, primary care itself, private rehab facilities, and telehealth. So I'm just gonna, before we release the poll is, oh, here we are. We are currently sending our patients. So most of you are continuing to outpatient clinics, 92%. That is awesome. Very good. Inpatient, 46%, some to primary care providers, federally qualified health centers, and 38. So we have really good representation of where we're sending our patients. So excellent. That really gives us the knowledge of where our patients are going. I think outpatient's the best. It kind of really allows them to have a more better life, right? So what are the benefits? Well, benefits are basically insurance, right? Federally qualified health centers, they accept Medi-Cal. So definitely that's a huge plus. Hospital outpatient clinics, they have increased resources and they connect to an emergency department. So that's really helpful. And urgent care, some urgent cares offer. And that benefit is walk-in and no appointment needed, right? And that's the same with all of our emergency rooms, no appointment needed. You can also send them to a clinic. You know, there were formerly methadone clinics, and some of them unfortunately still have that daily, but they can build they can build their rapport because sometimes they still require daily dosing. But for those medical units, those are like your Aegis, your Medmark, those are kind of the standard. Then there's residential inpatient, 24/7. And this really helps because it frees our patients from distractions and temptations. Some of your patients are gonna just tell you, I need inpatient, right? We hear that a lot. And then telemedicine, I think this really helps for patients that are on the road and are active and have work. You know, some of our patients are working. I remember I had a truck driver, and telemedicine was one thing that he could go anywhere and continue his treatment. So really good benefits. So the best thing is to build your resources, right? How do I do that? A lot of you have asked. And number one is Ask the people in the hospital already. Do not reinvent the wheel, you guys. Your social worker can help with so many resources, specifically if you have patients with dual diagnosis and behavioral health, right? Sometimes they have certain facilities that only cater to dual diagnosis. And I say that only because behavioral health, mental health illness is on the rise. So it's very, very important that you have a resource that you can connect patients for dual diagnosis. That means they have a mental health issue along with the substance use. So they are dual diagnosed and they need treatment for both. So again, go to your social worker, reach out to the existing resources and call them. Say, hey, not only, you know, do we have social worker, but now we have a son here, and I also want to transfer or refer our patients. Check for MAT clinics. Okay, if you're new and you're establishing your program, go on the SAMHSA MAT, and we'll put that in the chat in the link. SAMHSA is very important because you can type in your area and they'll tell you the MAT clinics. So very good, useful tool. And Google search. Just type in a Google search, MAT, in my area. And SAMHSA will probably come up with that. And then check your county or city's website. Very, very important, because sometimes there's already links to care for your website, on the city website. And you can just borrow from them and make connections. And then visit your referral sites, investigate. Do they take Medi-Cal? Will they carve out time for your referral? Are they friendly? Do they seem flexible? Are they abstinent focused, right? Because you know, will they accept patients that relapse? These are all really significant questions, because if you're not asking and you're sending them, your patient may come back and say, hey, that place, you know, they wouldn't give me MAT, you know? So really good to investigate about all of these places. Right now, I'm going to introduce our MVP, Tommy Trevino. All of you guys know him, you should. He's been here since California Bridge started, and he has a great story. Tommy, welcome, and please share your story about site visits, because you have some amazing things that you're doing when you go on a site visit. So please share.
Yeah, well, thank you, Sherry. Well, I have many sons that have shadowed me and kind of shared with them what I do is I, like Sherry shared earlier, I Googled the clinics around the closest to me in my county that I'm going to be working with, and I'll find out what kind of services they have. I'll call and make an appointment with the director, and then talk to the director about what kind of services they have and how we can work together to help our patients here in the emergency department. And I ask questions like, would they be able to help my patients with buprenorphine, naltrexone, and like Sherry mentioned, mental health, and all the other services they offer. Also interested in pain management, as now with the opiate crisis and all the laws changing there, those are changing, and I'm finding a lot of patients that they're taking away their opiates and trying to work with different medications for pain management. So that's also important. HIPAA laws, as far as sharing information with patients, how are we going to do that? So come up with a plan with that. And I also stay connected with them, like maybe go out to lunch with them once in a while, go have a cup of coffee with them, just build that relationship up and visit their site and just get a good feel of it. You know, the patients that go there, the doctors, meet the nurses that work there, and just build that relationship up with them and stay connected close. And that way I can follow up with my patients. If anything goes wrong, I have a patient that I referred to them and they keep coming back to the emergency room, I can call them up and say, hey, what's going on? You know, or they can call me up and say, hey, Tommy, this patient disappeared. Have you seen him? Etc. But anyway, I'm always here if anybody needs me. Thank you, Sherry.
Thank you, Tommy. Thank you for those sites. So we have a poll. We want to know, coming up with our next poll is, have you made a site visit? And here it is. We'll give you a few seconds to fill this out. We want to know if you've been out investigating, and it's okay if you put no. We know COVID restrictions and rules and regulations have changed and are constantly changing. So if you haven't, that's quite all right. I think Tommy gave some really good suggestions, specifically, you know, taking them out to lunch. At one point he told me take them some cookies or donuts, right?
Yeah.
Yeah, definitely. So those are great suggestions to make some good networking connections. Okay, we're going to close out the poll, and half of you, perfect, kind of right in the middle. Good job, you guys, making some site visits. Okay, next we're going to go to the continuity of care, and we have Latoya Mitchell. Is she here? Latoya is not here. Okay, so not a problem. We are going to continue forward. I'm sorry, we do not have our Sun mentor. Perhaps she'll join us later. Our Sun mentors are all taking patients actively. So that's kind of, we're still working, right? So for buprenorphine, part of your connecting to patients to follow-up care is the buprenorphine follow-up. Please make sure and ensure the patient can fill the prescription. Make sure the patient uses a familiar pharmacy and the one that can fill the buprenorphine. That's another investigation. Call the pharmacy that you're referring to make sure they're doing that. Some of them might not have it, or it takes a few days. Have the patient come back to the emergency within 3 days of discharge when needed. Remember, your physicians can give 3 doses within 72 hours, okay? X-Waiver is not needed. They can come back, 3 doses, 3 days, okay? And provide the patient with education at discharge about the medicine, okay? Very, very important, you guys. So we have a poll, one more poll again. How many buprenorphine prescriptions has your site given to patients in the last month? So we have a choice of, you haven't given any, that's okay. Like I said, just be honest, because we know some of you guys are referring to sites. 1 to 3, 4 to 9, and 10 plus. This depends if you have an X-Waiver. So your doctors have to have the X-Waiver for prescriptions. To give buprenorphine in the emergency room, they do not need an X-Waiver. They can give it up to 3 times, okay? So just want to clarify, these were some of the questions that were popping up on Slack, and you know, we just want to make sure everybody has the information, because when one person asks, that means other people have that same question, right? So again, how many? We're going to wrap this up in a few seconds and share our results as they're tabulating. Wow, so most of you are giving, it looks like from 1 to 10. So we are giving out prescriptions. That's excellent. We hopefully see this number rise because of the X-Waiver. The limitations are lifted, right? The guidelines are that they only have to apply. They don't have to do training. So hopefully these numbers will go up. For those 10 sites that are not giving prescriptions, we're here to help. Whatever that you need to facilitate, just let us know. Okay, and some other important considerations is confirm insurance in place of referral. What does the patient want? Very important. They may not want to go to a specific pharmacy. They may not have transportation. That's the next one. What is accessible for the patient? And really make sure you give them that safe medication storage, all the information, okay? We don't want them not to know to store it in a safe place. Make sure, you know, it's out of reach of children. Make sure they take it the same time. They leave it under their tongue, right? All of those things, really, before they leave, you need to follow up with and give them the education. Okay, so next we're going to do a couple of scenarios with our Sun mentors. The warm handoff, calling an outpatient clinic for referral. This is going to be done by Rebecca Bartley and Wendy Martinez, and they're in our Sun mentors down in Southern California. Rebecca and Wendy, are you ready?
Yes. Hi, everyone. So we're going to do first off a scenario first that is a warm handoff. So it is the substance use navigator, which is going to be played by Wendy, calling a follow-up provider, so someone who's helping you schedule patients and ensuring that that process goes smoothly. So here we go on our best acting skills.
Hello, Paula. I have a participant in the ED today who has chosen to follow up for MAT counseling at the First Step Recovery Center, and they currently don't have a phone.
Great. I can get them in on Monday, the 24th at 9 a.m. to see the doctor. And since they don't have a phone, we'll make sure to be flexible for them. Please tell them they can drop by anytime, Monday through Friday, 9 a.m. to 5 p.m. if they need anything.
Awesome. Thank you. I'll tell them about the appointment for 9 a.m. on Monday, and I'll let them know that they can come into the ER to talk to me during my hours or leave a handwritten message for me if I'm not here. I can also relay messages to you if needed. They have a Blue Shield PPO plan, and I'll fax the ROI, the release of information, right over.
Okay, sounds great. I'll reach out to you on Monday and confirm if your participant was able to see the doctor here and get their next prescription.
Okay, thanks. And if there's any issues, please let me know. I can request a refill on Suboxone from the prescribing PA. Oh yeah, and also, do they need to come in before Monday to fill out intake paperwork?
Oh yes, please, that'd be great. If they're feeling well enough today, they can come in after their ER visit. If not, tomorrow, anytime between 9 a.m. and 4 p.m. works. But since they don't have a phone, I'll make sure the doctor appointment on Monday is first priority though.
Great. I'll make sure they have a prescription to cover them up until then. And just let me know if there's any issues with the follow-up. We've got this participant's information and we got their back. And we're definitely going to be going through the journey with him. So thank you so much, Paula.
Thank you. I really appreciate your help. Yeah, we'll be in touch on Monday.
Okay.
Bye.
Bye.
So that's an example of a referral warm handoff that goes really well. Someone got an appointment, and the next couple of days they've got a prescription to bridge them. You're talking to your follow-up people to make sure that if they need any additional assistance with refills, that the participants are covered. And then in this scenario, the son would email the follow-up provider and confirm that the participant did make it to their appointment on Monday. Call or email. Just make sure you're following your company's release of information and HIPAA compliance rules, and that it all went well for the participant.
Great, Rebecca, that is great. Thank you. I really like the follow-up with the email to make sure. Great job. We know Wendy's mic is a little cutting out. We have one more scenario, so please, Wendy, can you get a little closer and speak slower and louder, so that way the caption, if you're following by caption, you can read it. Okay, scenario 2, the follow-up. Guys ready?
Yes.
Yes.
Hi. Are you there?
Yes. Hello.
Hey, this is Rebecca, the substance use navigator. We met yesterday in the emergency room. I was just following up to see how you're doing today.
Hi. Thank you for calling me. I'm actually doing really well, just a little tired.
Okay, got it. Were you able to pick up your prescription last night after you got discharged and we said goodbye? I wanted to make sure that that all went okay for you.
Yes, everything went as planned. I was
Okay,
able to
good.
pick up my prescription with no problems.
Awesome. Did you take your first dose today?
I did. And again, I just feel a little tired, but other than that, I feel amazing, better than I felt in a long time.
Oh, I'm so glad to hear that. Yeah, it's really typical for folks to say that, they're feeling better, that there's kind of like a normalcy and clarity that comes around taking buprenorphine. But if you have any issues at all, I'm here. I've got your back. You can call me anytime you need me, call or text me. And your follow-up appointment is tomorrow at 9 a.m. And we went over the address and the phone number of First Step Recovery Center yesterday. Do you feel good about going to your follow-up appointment tomorrow?
Yes, I'm actually looking forward to it so I can start my healing process. And
Awesome.
I just want to thank you for all the help that you've given me. And I'm glad to know that I can call you anytime.
Yeah, absolutely. And if it's ever after hours, just send me a text and I'll see it right when I get in the next day. And the ER is there for you. I'm there for you. If you need anything, please reach out. If you have any issues tomorrow, First Step, call me immediately. I'm here for you. I want to make sure this all goes smoothly for you.
Thank you so much. This is the most support that I've felt in a very long time. And I feel that my recovery is going to go through.
That's awesome, Wendy. I got your back, okay? So I'm here if you need me. Call me and let me know how it goes tomorrow, okay?
Okay, thank you.
Okay, thanks. Have a good rest of your day. Bye.
You too. Bye-bye.
That was awesome, you guys. Yay. That was a great representation. Definitely about the follow-up. So important, you guys. Following up, making sure they got their prescription, their intake. That's why they're your son mentors. What can I say? I'm so proud. They are just awesome. And again, reach out to them if you're having problems with any part of this scenario or any part of the process. They've been there, they've done it, and they're really up to helping you guys. Your success is our success. Before we move on to navigating insurance, I did want to clarify, there is still an X waiver provision. Your doctors for prescriptions have to sign up for the X waiver, okay? To give buprenorphine in the emergency room, any physician can give buprenorphine in the emergency room setting. Okay, so those are two different topics. One is giving buprenorphine in the emergency room, no X waiver required. There is, however, an X waiver required for giving a prescription, and that's, I believe they put that in the chat on giving that information to your doctors. So any other questions about that, please let us know and we can guide you the correct way. So next up, Christian, are you here? We have again, one of our wonderful son mentors, Christian Helosian. Hello, Christian.
I am here. Hello.
Hi, we're going to talk about his favorite subject. He was very passionate when we did this in rehearsal. So Christian, please enlighten us about navigating insurance.
Hi, everyone. My name is Christian. I'm one of the substance use navigators here at Highland Hospital. So this part is one of the most important parts of being a navigator, and it's helping your patients navigate insurance. So you can see on the screen here, there's 4 big bullet points. Depending on what site you're at, if you're part of a hospital system or if you're a county hospital, you may or may not see more of these types of insurances. The first one is Medi-Cal. Essentially, that's, Obamacare, but for the state of California, it's called Medi-Cal. These are, mostly patients who are low income and who show up at your county hospitals. There's different types of it. There's emergency Medi-Cal, which you can get your patients to acquire, on site immediately. There's managed care Medi-Cal, which is, signing up through a program like Covered California. And the cool thing about Medi-Cal is that all forms of MAT, so Suboxone, Subutex, buprenorphine, is covered if they have Medi-Cal. So they can pick up at, your local CVS, Walgreens, Safeway, any place that they accept that type of insurance. Medicare. So Medicare is, for 65 plus or if you have a disability. Again, most sites, almost every site will take Medicare. The thing to know about Medicare is for Suboxone, buprenorphine, there is usually a copay. It's usually a small one. And there also may be a prior authorization requirement, especially if you're at outside pharmacies. So this can be a little bit of a challenge to navigate. And if that happens, I would highly encourage you to go to your Sun mentor, because they can really, really help with that. Dual Medi-Medi is a patient who has both Medicare and Medi-Cal. And the important thing to know about that is that the Medicare, which is quote unquote the better insurance, will take priority. So if they have dual insurance Medi-Medi, you are assuming that they have Medicare. And then the last one is private insurance. So these are for navigators who are at a system, so Kaiser, Sutter, etc. Or if you have a patient who actually has active employment insurance, or for patients who may be under 26 years old, they may still be on their parents' insurance. So private insurance can be difficult because you may not know whether Suboxone or buprenorphine is covered, and there usually is a much higher copay when picking up those medications. So these are all things to know. Again, this is recorded, and this is something you're going to have to learn within your county and with neighboring sites. So I would always highly encourage you to build a relationship with your financial people at your site, as well as using your Sun mentors within your region to really help navigate that stuff. I'm from the Bay Area region, so I know Bay Area Medi-Cal insurance really well. But if you're in SoCal or if you're in the Central Valley, maybe reaching out to that Sun mentor would be something to do. And yeah, insurance, it's super important. You can do the most you can for a patient in the emergency department, but they can't pick up their prescription, they're going to probably end up back in your emergency department or not being able to continue their care. So it's a big part of substance use navigation for our patients.
Thank you, Christian. I have a question. I know probably some of our sons, because when sons are starting out, the biggest challenge was for me was pharmacy.
Mm-hmm.
They would tell us it wasn't covered. And so we had to learn and investigate. What are some tips with the medication?
I would say the first thing is making sure that the patient has a copy of their insurance card, or you can print out their insurance information and give it to the patient. A lot of times outside pharmacies are difficult to work with. And this is not just in terms of Suboxone, this is just in general. So they won't do that extra legwork and groundwork to kind of really help facilitate that patient getting their meds. And that's kind of where you as the navigator can really help put out a fire before it even starts. I would also say getting to know your pharmacies, your local pharmacies around your site, the most common pharmacies that your patients go to, and again, building a relationship with them. So you get to know who the pharmacists are there and who the pharmacy techs there are, and maybe one or two go-to people in that pharmacy. So that way, if your patient does have an insurance issue, you have someone to go to there who can help sort that out. Those would be my key things. If you are fortunate to have a pharmacy within your hospital, that will make your life a lot easier. And sending your patients there will make your life a lot easier. But I understand that not every site has, an inpatient or outpatient dispensing pharmacy within their hospital.
Okay. And do you know if they need a pre-auth for the medication?
Yeah. Yes and no. So sometimes you will, sometimes you won't. It's for Medi-Cal, they usually don't. usually don't. For Medicare, it's 50-50. It can make it, I've had some pharmacies, especially outside pharmacies, who have never asked for a prior authorization, and I've had some that always ask for one. And again, this is something that there's no cookie cutter answer to. I think it's almost county by county, pharmacy by pharmacy based, and it's a little bit of legwork and pre-work that you as the navigator are going to have to do. I would say that if they're requiring a prior authorization, you know, that's something that you can bring up to your prescribing physician to see if you can maybe switch it to a different pharmacy, switch the prescription to a different pharmacy, or try and get that prior authorization fast tracked as quick as possible, and maybe have the patient return the next day just for one extra dose while that prior authorization gets through. I think that's totally okay. Because ultimately, that prior authorization may need to go through anyway for their continuation of care, you know, when they land in clinic. So, yeah.
I have a question from Eric, and there's plenty of going on about this insurance and medication. So I'm glad we have a focus here. Do we have any solution for patients to pick up medication? I'm not sure, Eric, what that means. Do you mean if they don't have an ID or if they don't have money? I'm not sure. Urgent auth requests can be done as well. Alana Bush has mentioned.
Yeah, urgent authorization requests usually still take 24 hours. And the reason it's a challenge is because that's actually when the patient is still most vulnerable, is within that 24-hour window from discharge. So yes, urgent authorization requests can be done, but there's still a process to it, and you are working with Medi-Cal and Medicare, and they're not the most efficient all the time. So
Right. What I hear is being persistent, right?
Yeah.
I think our sons are very good at being persistent, because I know even calling a pharmacy, you might get different answers with whoever answers the phone.
Right.
Have you had, you know, I've had that problem myself. So there's some more questions on there. A pharmacy held Suboxone because a patient county report was it was too soon to pick up. And we could help out with inviting them to come to, you know, the emergency room to get a dose if that's the case. You know, we can kind of work with our docs that they understand that it's not so easy to fill a prescription. It also says if a pharmacy says, Christine writes, if a pharmacy says it's to communicate with your patient to determine why they are out so early, they can prescribe a dose change and release the prescription early. Great answer, Kristen. And that's what we're here for. You know, we always have Slack time, our TA time. And when you have those challenges, please let us know, okay? Put them on Slack, because just from today, we have many questions. And if you're not part of Slack, please let us know. If you're from the community or you're a community partner, we have started a Slack channel for community. So we're happy to offer that. So just let us know. Right now, what's next steps? Chaya, can you just go over our checklist for Sun Referral?
Yes. Hi, everyone. My name is Chaya, and these are just things that you need to double check when you're doing a referral, okay? So the first thing is setting up an appointment and arranging times at a clinic to see your patients. Giving them a specific time and date kind of gives them some sense of stability that they're gonna have somebody there to see them. And they call the facility and provide a warm handoff. Usually, I suggest doing this when the patient is with you. That way they hear that you're on the phone with the facility, and they know for sure that the facility knows they're going. Provide buprenorphine administration if possible, or if not, prescription, and including prescription information, and including then the pharmacy information. where it is, and just telling and confirming the prescription is received at the pharmacy. That really helps, so the patient doesn't have to go back and forth, coming back and asking, oh, my prescription wasn't there, what do I do now? So just confirming that the prescription is at the pharmacy is an extra step that we can do to help the patient from having to come back to us. Give patient written up information, follow-up information, and providing harm reduction kit. Not all sites have harm reduction kits yet, which may be a Narcan kit, fentanyl strips, straws for safer use. If you don't have Narcan yet, it's okay. Just remind your provider to prescribe it for the patient. And also in your written up information, provide the clinic address and phone number for the patient too. Stay connected, follow up, so you can follow up within 5 to 30 days post-discharge. Get a good working phone number for the patient if possible. And also give your phone number to them so they can call you if anything happens. So that way you can call them or they can call you some way, somehow. And log and document your referrals. That just covers your back if something does happen and they come back into ER and the provider is going to ask you, well, what happened last time? At least you have a documentation that this is what we did the last time they were here. Okay.
Great. Thank you so much, Shaya. That's a great checklist. Okay, I see Josh is here. I am so excited to announce. I'm going to stop my screen. So Josh is a Department of Emergency Medicine physician assistant. He is investigator and clinical instructor of emergency regional anesthesia at Highland Hospital for Alameda Health System. And he is also the Bay Area Regional Director for the California Bridge. This is just a short list, Josh. I know you do so much more. So we're honored to have you. And he's going to talk about the naloxone distribution program, which he has so much passion, and I am so excited because I love this topic. Josh, I'm leaving it to you.
Okay, great. Thank you so much for having me here, and I'm really excited to be connecting directly with the Sons on this really important topic that as you said, I'm really, really passionate about, and I'm really excited about sort of where things have been going with this and what the future will bring. So first off, I just want to make sure you can see my screen. Screen's okay? We're good on that? Great. Okay, so normal disclosures, and I have no financial disclosures or conflicts of interest. Where have we come from? So the impact statewide initially in 2018, we'll just take a moment to reflect of sort of the pace of change. So in 2018, there were no emergency departments with high impact naloxone distribution. And in fact, when I was starting the program at Highland, I was told that it was not possible to do. Fast forward to the present day, and we have 47 emergency departments distributing naloxone and over 34,000 kits available for free distribution. So it is absolutely doable at every emergency department in the state, and we're getting there. We're making our way forward to have this the reality. What is naloxone? I think everyone on this call probably has a good sense of what it is. We're just going to go over some basics. Safe medication reverses opioid overdose and blocks opioids for 30 to 90 minutes. It is not a controlled substance. It does no harm. It's well studied. There's no known negative effects, no known allergic reactions, no potential for abuse, and no street value. These are things that you probably don't need to hear, but other people in your hospital may need to hear. There's been also community, it's not new. Community distribution is not new. It's been being done across the United States since the 1990s. And the nasal spray is relatively inexpensive and simple to administer. As we know, naloxone acts by outcompeting the opioid on the mu receptor, which you see as this green blob coming in and knocking the opioid off, so in an overdose situation. And then it occupies that receptor, but then it will eventually wear off. And then if you have a long-acting opioid, it can go back onto the receptor, and that's where you worry about keeping, staying with the patient even after, that 30 to 90 minutes. The formulations that we have that are commonly available come in. There's 4 main formulations. On the upper right, going around in a clockwise manner. On the upper right, you have the auto injector, which is very expensive and is not suitable for this process. On the lower bottom, you have the injectable, which is syringe access services use the injectable, and that's also not great for ER distribution. There's the self-assembled nasal spray, which is complicated to use. And the one that we're focused on, the one we're using across California in emergency departments, is the nasal spray. It's very simple to use. It's the upper left corner. You just put it in the nose and push the plunger in. That's it. Why is the ED an amazing place to do distribution? We have 28% of the patients that screen, depending on which data you're looking at, we have around 28% of patients that screen positive for substance use disorder. And when you do the math on the numbers, you get some really high numbers. So you take, like, Highland Hospital has 65,000 patient visits a year. You figure a quarter of them have substance use disorder, and you knock off maybe half of those maybe are alcohol related, and you still have like 8,000 patients that should be getting kits. And then if you think about their support, that probably each person should get a couple kits. They should get a backup kit. They should get one for their loved one or friend to carry. So you get into the thousands and thousands of kits that should be going out every year pretty quickly. And then post-overdose, people don't go to clinics and pharmacies or public health clinics that they might be able to get naloxone from after they have an overdose. They actually are brought into the ED. And we know that there's also this window, this spike. This shows the mortality after an overdose and days after that visit where they have increased risk of mortality. And that is within the first 72 hours. And that's when basically typically the only healthcare contact they have is that visit to the ED. And that's when they have to receive naloxone. No one else can provide that emergent dose of naloxone for them to take home. And we want naloxone for all. So we do an amazing job. I mean, the whole California Bridge model and the work you guys are doing as substance use navigators is doing, having this big impact. We're getting so many people into treatment. We're getting them engaged in the follow-up care, but we're not getting everyone. We want everyone to get naloxone. So even the people that are not engaged in treatment, we want to meet people where they're at, and they should go home with naloxone. Your hospital system may be thinking, we got this covered, we're prescribing. Okay, so the problem with prescribing is that only 11% of people who should be getting a prescription are getting that prescription. And then the people that are actually filling that prescription is down at 1.6%. So people do not fill those prescriptions. There's co-pays, there's other barriers, it's another trip to the pharmacy. For whatever reason, it all adds up to almost no impact from prescribing. There's many other processes for distributing naloxone. We talked about prescribing. There's also, the ED pharmacist can run down to the pharmacy and run back up and hand deliver it. It's very time consuming. You can have the pharmacist can furnish directly, and there's a lot of limitations to that. Like you can actually walk into a pharmacy and receive naloxone in California without a prescription. Most people don't know that. Most pharmacists don't know that. It's not a mechanism that's actually widely used. And then there's ED dispensing, but having a limited program where you have maybe just a few kits and they're locked up somewhere where they're not easily accessible. That's not what we're talking about. We're talking about high volume, low threshold, very accessible naloxone flying out the door. Does this, and this is the message that you have to, as you're talking to other people at your site who maybe are skeptical about what you're doing, does it save lives? Absolutely. These are some of the numbers. Just having laws that permit naloxone access will decrease the deaths by 9 to 11%. And then they had a great study in Massachusetts where just having naloxone in the community had a tremendous impact on the fatality rate. Does it encourage risky behavior? No, it does not. That's one myth that people may have. And people who use drugs who reversed overdose with naloxone did not use more opioids after receiving kits. Let's talk about what low barrier, high volume distribution actually looks like. So these are the elements. Naloxone kits are easily accessible. Anyone can distribute naloxone. So the nurses, techs, you have a system where anyone can actually pass it out. But the sons, of course, are leading the charge. You guys are you're doing when you're active, you're doing most of this work and you're setting an example. And the process is very simple. You have minimal documentation requirements. You don't want to have a lot of paperwork associated to it that's going to just burden your program, slow it down, make it harder. You want it easy to give multiple kits to recipients, not just one kit. You know, it's really as much as they need, they'll get. And you want the recipients to be able to be not only patients, but their family, friends, or visitors. So they don't have to be a registered patient to receive naloxone, and they can remain anonymous. And again, they don't have to register as a patient to just receive it. They can actually walk up to the lobby, to the counter, to the intake area and just say, hey, I heard that I can get naloxone here, and great, you just pass it across the counter. They're not even a patient, they stay anonymous. And you have 24/7, 365 availability. So you have a process that will sustain itself even when this during after hours, when the substance use navigator is off duty. People know that how to access their the kits and how to pass them out. And what do you get from all those elements? When you put all the elements together, this is one site, this is our pilot site, this is Highland Hospital in Oakland. Before we had low barrier, high volume distribution, we were getting about 7 kits in people's hands a month. That was mainly through prescriptions being filled. Once we implemented, that number skyrocketed. We had 65 times the amount and increased in distribution rate, resulting in 452 kits in hand per month. So just day and night. Here's how you get from A to B. Here's a step-by-step recipe for success. Step 1, review the naloxone guide, which is the guide to naloxone distribution. You can hold your phone up and scan that QR code or go to our website. Hopefully many of you have already seen this document. It's pretty prominent. Just find it in the resources on our webpage. The substance use navigator and the champion should become familiar with this guide. Just read through it. It'll help clarify things. Then you're going to share that guide with 3 important people at your institution. That's going to be the ED medical director, the ED nurse manager, and the pharmacy director. And they can look through the guide. That'll answer a lot of questions, so you don't have to answer those questions. It's answered for them. And then one thing to bear in mind is that the program is run by the emergency department, not the pharmacy department. It's really crucial that is clarified from the beginning, and it's in everyone's best interest. It's in the pharmacy's best interest to not run the program. Instinctively, they'll think they're supposed to run it because it's a medication, but that's not the way to go. Then the Sun uses these templates. There are all these supporting documents. They're templated. You can see they're just the yellow parts where you put in your hospital name. This takes 5 to 10 minutes to fill in all these documents, just typing in their Word documents. You go find and replace, put in your hospital name, put in your name, fill everything in. Easy. Then you take the standing order, which is one of those documents, and you have the champion sign it. And that's going to cover all the naloxone distribution from the site for 5 years. And you take all that stuff, you download and complete the NDP application. This is a 1-pager application. Again, it takes like 5 minutes, and it's mainly wanting to know your name and address. And the substance use navigator can list themselves as the authorized person filling this out. The kits you're going to order are up to 2,400 kits at a time, but you can reorder as much as you need. So it's very generous. And step 6 is you're going to take the application that you filled out, take all the supporting documents. I mean, every single shredded document. There's basically 10 documents in there, and you're going to put them together as attachments on an email that goes to the naloxone email address, which is listed here. By the way, you're going to receive everything on these steps in another. Sherry can probably help me email these out. So we'll get these to you, and you don't have to remember everything here. So you'll mail it into the naloxone at dhcs.california.gov email address, and if you can please CC myself and Elizabeth Allen, and that's our email address. That'll be on the documents you get. And that will help us troubleshoot the process as you go forward to just make sure there's no issues and make sure you're on the glide path to getting your application accepted. And then you're going to receive naloxone. Usually takes a week or 2, and you're going to get a shipment, and you're going to be very happy. Labels for added impact. So by putting labels on your kits, you provide a link to health and treatment along with that life-saving antidote. I like having 3 labels on there. The top label is a call to action. It says carry naloxone and save a life. The next label is a suicide prevention lifeline hotline. And then I'm going to zoom in on the bottom label. This label is typically the son's work phone number, and then just clear language: struggling with pain pills or heroin, try buprenorphine today, call or text this number. Peer distribution for the win. So when we give naloxone out, there's an opportunity that I want everyone to recognize, which is that giving multiple kits to someone, they have a network where they can do peer distribution in a way that we cannot, that no one else can access that network in the same way. It's so powerful to have someone who's, say, heading back to a tent encampment and brings naloxone kits to their friends and family in that environment. They're a force multiplier. It's really empowering. They partner with you. It's a great way to access an incredibly high-risk population and really push down the fatality rate. Part of the scripting you can use to get people to buy into receiving naloxone and peer distributing naloxone is just basic language. I'm going to give you just a moment to just look at this and kind of read through this. I'm not going to read it all aloud. Okay, and the basic message is, can you help us get it out to the community, to people who should probably have it around? How many kits can I get you? 4, 5 kits? You know, you kind of anchor at a number and they're like, oh, I need 2 or whatever, but you just kind of really clarify that they can have multiple kits. Your program, when you set it up, will become a catalyst for community change. So at Highland, for example, we have many community partners, slide this up a little bit, which are nonprofit community organizations, homeless service agencies, youth outreach programs, all have now started distributing naloxone. They were not at all involved in this activity, and because Highland moved forward and is doing tons of distribution, it is now sort of caught fire at all these other adjacent nonprofits that are now involved in this, and now having, so it's all these ripple effects coming out of this one program. We've also engaged law enforcement. So Oakland police, instead of arresting people for substance use, are now passing out naloxone. I mean, it's just such a huge win. And then you can also expand internally. So when you can bring kits up to like OBGYN or other clinics and bring a log sheet, and you'll keep resupplying them and just collecting the log sheets. And it's a way to just expand the impact internally across your hospital system. If you have any issues, I want you to please contact me. And this is how you contact me. So you're going to email me, or you're going to text me or call me. I love getting texts. It's a great way to just kind of quickly respond to things. But please email, call me, help me troubleshoot any issues that are coming up. You should all be able to get naloxone going. If you have any problems at all, please immediately let me know, and I'll help your process along at your site.
Thank you so much, Josh. This is so great. And I'm reminding everybody, we will send out your slide deck. We will make sure that that is accessible to them, as
Great.
well as the naloxone guide on our website. Everything we talked about today can be found on our website. So if you haven't one on there, it's truly, the place to go. So I'm going to wrap this up. Josh, can you and share your screen? Perfect. Okay. So we're going to wrap this up. I know there was a lot of information, and we thank Josh. It was so important for him to come and talk, and out of his time, like I said, he's double booked, but he did this for us. So there's our takeaways. We learned a lot more than this. Please fill out the evaluation form to receive your CEQ credit. If you're here, we'll put that in the chat. Very important. And next month at our regional meeting, we were supposed to introduce our trauma-informed care self-learning module. It is online. You can read this at your own leisure, but we're honored. We're going to invite our authors, and it's called Meet the Author. So if you have time, please read before June 17th. Is the day that we will have a Slack support time. And if you have any questions, and what is trauma-informed care, you need to read. It's really about childhood adverse experiences and how that relates to substance use disorder. This was specifically written for our substance use navigators. So please go online, read the document, and June 17th on our Slack TA time, support time, question time. Josh, I just wanted to wrap up. Are you available to answer any questions at 2:30 on our Slack time today, if you're still here? I don't know if he's still with us. I'm going to say that he can, probably we can get him some questions. If you guys have questions more for Josh today at 2:30, please join us for our Slack support time, okay? And again, these are our websites. This is our bridge team. Thank you, Josh, for our wonderful presentation. I always like to thank our program staff. They are behind the scenes making sure everything goes correctly. And that's Francesca, Caroline, Aria. You are the best. I always call them rock stars because they make us all look better. And then, of course, our Sun mentors, Rebecca, Angela, Christian. Eric's not with us today. Wendy, Latoya, and of course, Tommy. So again, we thank you. Again, any questions, I am always available. You can text me, you can email me. And if you have more questions, we can carry this on at 2:30 on our Slack time. I am sorry we went a little bit over, but we will see you soon at our next Sun training is June, and we will send out emails. Okay, guys, thank you and have a great afternoon. Bye-bye.